Dear students, how are you today? Hope you're all well and fine. I'm Dr. Soha Ghobashy. I'm Professor of Psychiatry, Neuropsychiatric Department, Faculty of Medicine, Alexandria University. I would like to discuss with you mood disorders. First, I would like to take you into the definitions of mood and affect. So, mood is what you feel inside. It's your internal emotional tone. This emotional experience colors your perception of the environment. So if you're seeing it happy and optimistic, you see all the positive things around you, and vice versa. While the affect is the way that you express your feelings, your emotional tone. It's the expression of your mood. You find it in your mental state examination. And usually it is either said verbally, so you ask your patient, how do you feel? And it is expressed externally on his facial gestures and his body posture. So when something goes wrong, we get a mood disorder. These are psychiatric disorders concerned with the parameter, as we see here the emojis, from the depression to the happiness. And this parameter, this mood parameter, can be affected anywhere in between the depression and the happiness. The psychiatric disorders concerned here has three characters. They are episodic. They come in remission and relapse, and between the episodes, the patient is completely free of any symptoms. And some of the episodes, like the manic episodes and the depressive episodes, may have psychotic features. So hopefully by this lecture, we can acquire the knowledge of the different types of moods, epidemiological data, and etiology. And we can acquire the skill of diagnosing the major depression through the assessment by the history-taking examination and different investigations. And lastly, we can acquire the skill of putting a management plan and converting it and communicating it to the patient and his caregivers. So the first part of our lecture is the types of mood disorders. So again, the mood disorders are classified into depressive disorders and bipolar disorders, as we see these two pictures. So the one is depressed and the other is bipolar, is happy, and have a sunny cloud and she's really happy about it. So the depressive disorders only include depressive episodes only, while the bipolar disorders, they have both the depressive episodes and the bipolar episodes. Three depressive disorders you have to know as a graduate student. This are the major depression, the adjustment disorder, depressive type, and lastly the persistent depressive disorder. While two bipolar disorders only you have to know as a graduate student, the bipolar 1 disorder and the bipolar 2 disorder. Okay, so let me give you a brief about the major depression. Major depression is one of the depressive disorders. It has only recurrent depressive episodes. The depressive episodes has lots of specifiers that we are going to discuss in the clinical picture shortly. And it is of biological origin. Usually it is not due to a great stressor or trauma that the patient is exposed to. The adjustment disorder on the other side is adjustment disorder due to a stressor that the patient has encountered in his life and he cannot cope with it. So some depressive symptoms will be developed. So this is the adjustment disorder depressive type. The persistent depressive disorder was used to be called dysthymia. And dysthymia means the feeling of being sad or being not at ease with his mood. So it is a minor depression, but it's for a long period. It must be a chronic course. For the adults, a duration of 2 years is indicated, while for adolescents and childhood only 1 year is needed to diagnose the persistent depressive disorder. For the bipolar disorders, we said here that we have a mixture of episodes on one side, which is the depression, and the other side, which is mania, and we have another small episode, which is called hypomania. If we have a manic episode, so this is a big one, so we will have the first bipolar disorder, which is the bipolar 1 disorder. If the patient lacks a manic episode but encounters a hypomanic episode, then we can diagnose the bipolar 2 disorder, which is the smaller type of the disorder. So these are the different types, and we know shortly their epidemiological data and clinical picture and management. For the epidemiology, the DALYs is the Disability Adjusted Life Years. This is an institution that counts the disability produced by the different disorders. The DALYs has found that unipolar depression is the leading cause of disability worldwide from the ages of 15 to 44 years, while the bipolar is the fifth disorder that causes disability. This is according to the World Health Organization data 2001. As for the age and gender and prevalence rate for the bipolar disorder and the depressive disorders, we have the following numbers I would like you to know. For example, the age prevalence. For depressive disorder, it peaks around 40, while for the bipolar, it peaks around the late adolescence and early adulthood. For the gender, equal gender ratio is found in bipolar disorder, while in depressive disorder, the female has a higher prevalence, and it might reach the 2-to-1 or even 3-to-1. For the prevalence rate, bipolar disorder ranges, there are a lot of bipolar disorders, so it ranges actually from 1 to 2.2 to 1 to 2.8%, while in the depressive disorder, it ranges from 5 to 17%. Now, for the etiology of the mood disorders and any psychiatric disorders is the interaction between genes and environment. So, in a vulnerable patient, he will have the heritability of a certain disorder like schizophrenia or a bipolar disorder or depressive disorder. This will be a vulnerability in the patient. When he encounters environmental problems like stressors, traumas, adverse childhood experiences, it will precipitate in a vulnerable patient the disorder, which we call the phenotype. It might be a bipolar 1, bipolar 2, it might be major depression, it might be dysthymia, it might be schizophrenia. So this is the state of art and the current understanding of all the psychiatric disorders. It's a gene-environment interaction with the different genes and with the different environmental stressors. So if we look for the biological vulnerability in patients with mood disorder, we always incriminate the neuroanatomical or neurostructural abnormalities found there. We have a circuit that comes from the cortex, it goes to the thalamus, and then it goes to the limbic system and joins the cerebellum. This circuit is incriminated to be the problem in attending to the moods in patients with mood disorders, mainly the orbitofrontal cortex and the medial prefrontal cortex. It comes from there because this gives you the quality of the mood. That you feel sad, you feel happy, you feel elated, you feel anxious. It comes from this prefrontal cortex. This is the quality of mood. And then it conducted through the circuit that we just mentioned. Any abnormalities there, which was actually found with many imaging and PET scanning, will cause a problem in the mood. The second theory that we all have been nailing is the neurochemical theory, where the monoamines, we have monoamines neurotransmitters in the brain responsible for our mood, mainly the catecholamines, noradrenaline and adrenaline, the indolamines, the serotonin, and the acetylcholine. All these with the dopamine for, in the catecholamines category is incriminated for the mood disorders. It has been well known as the monoamine hypothesis of mood disorder. First, it was said that the serotonin, the catecholamines, dopamine, noradrenaline, and the adrenaline are present with a decreased amount, and then a little bit recently it was elaborated that it might be not functioning well, so it's rather not the quantity but the quality and the sensitivity of monoamines to the receptors in our brain. And then we come to the neuroendocrinal theory, which always nail the adrenocortical thalamus pathway, which comes from the pituitary gland, and then it goes to the adrenal glands. The pronounced hormone here is the corticotrophic releasing hormone, which influences the adrenal gland secretion of cortisol, and the cortisol is known as the stress hormone. Its increase actually gives a feedback on the structural abnormalities that we have just mentioned in the corticothalamus striatal circuit and the hippocampus, and it produces a lot of degenerative processes in our brain, where especially in the anatomical places responsible for the mood. Again, another axis, endocrinal axis, is the thyroid axis, which is again incriminated in the pathology of mood disorder, and that's why in every mood disorder patient we need to check the thyroid hormones, and it greatly influences the response to treatment. And lastly, the gene and family studies. We don't have one gene. We have lots of family studies incriminating that the monozygotic twins concordance rate is higher than the dizygotic concordance rates, which proves that it is a heritable disease, more prominent in the bipolar than the depressive disorders. However, we don't have one gene. Many of the candidate genes have been investigated, like the serotonin, the dopamine transporter genes, and many has been replicated in studies, and other studies nullified. So until now, we don't have one gene that we can nail down to the pathology of mood disorders. However, we have lots of genes and still in search for the specific genes. So the mixture of the neurostructural, neurochemical, neuroendocrinal, and genes make a patient vulnerable to have the mood disorder. He stays in his life waiting to be exposed to stressor, one stressor, lots of stressors. It differs according to the psychological coping strategies of a patient, and the many adverse childhood experiences that opposes his resilience and protection from the disorder. So in a vulnerable patient, he will keep counting the stressors that he meets in his life, or the adverse childhood experience, like the abuse, like the neglect from the parents, like school deprivation, like a problem with meeting his girlfriend, or a problem with having to be popular in school, or his achievements at school. So all these are stresses for him. and in a vulnerable patient, it will precipitate one of the mood disorders that we have today. So this concludes our etiology, epidemiology, and the types, and I would like you to go through these MCQs just to get a catch of what we have said and check your understanding for the last part. The answers is made in the second slide, and then we go to the clinical picture for mood disorders. I would like you to know that we are going to meet a patient with certain symptoms. You, as a clever doctor, you need to elicit these symptoms and signs and put them in a certain duration to get the first part of your diagnosis, the episodes. In the DSM-5, this is the Diagnostic and Statistical Manual of Psychiatric Disorder number 5, we have 3 types of episodes only: the manic, the hypomanic, and the depressive episode. Before that, we had another episode that was called mixed, and we will mention it shortly as a part of your knowledge. Anyways, so the patient will come, you will elicit the symptoms, you will have a certain duration, and you will diagnose the manic episode. So the first episode I would like to discuss with you is the manic episode. The manic episode comes with abnormal and persistent elation and expansive or irritable mood with high energy. The patient is so energetic, he cannot sleep, he's moving all the time, plus an infectious mood that he is happy, what we call elation. Elation is not only happiness, but with the happiness or the mood that is cheerful, more cheerful than usual, is associated with a sense of self-confidence and sometimes grandiosity. So it's not only happiness, but with an air of self-confidence or grandiosity. At the same time, the criteria entitles that he's so energetic. And then we need, plus the energy, plus the elation, 3 or 4 symptoms from the item B in the diagnosis. So when do we need the 3 symptoms? When we have a pure elated mood. When do we need the 4 symptoms? When we have an irritable mood. The irritable mood is not a typical mood for the mania or the hypomania. It is present even in the depression. It is present in the anxiety disorders. So it's not a specific mood for the mania, and that's why we need here 4 symptoms rather than 3 symptoms to fulfill our diagnosis. So the symptoms that comes in item B is the inflated self-esteem or grandiosity. The patient feels that he's more confident, that he's better than others, that he's becoming a knowledgeable person, rich. He might encounter some false belief about his superpowers, that he can influence the world. This is usually called the delusion of grandeur. It comes in richness, it comes in power, and sometimes it comes in the religious attitude that he is the prophet, that he is the one that God sent him to save the world from the devil. So it comes usually in these 3 categories: worth, wealth, power, and religion. So this is the delusion of grandeur, and it is, as you see, mood congruent. It comes with the feeling of he's confident and he's happy. So it is a mood congruent delusion in a manic episode. Other delusions can be encountered, like reference and persecution, but the pathognomonic delusions in mania is the delusion of grandeur. Then, as we said, this patient is energetic, so he has no need for sleep. Usually we encounter total or in global insomnia. Then he has racing thoughts because this patient is energetic. Also, again, his mind is so full of thoughts, and it traces from the economics to the religion to the science. It traces everywhere, in every channel in life. And then this is reflected in his talk, so his hyper-talkativeness, and sometimes we can interrupt him to stop. So this is hyper-talkativeness, but sometimes you cannot stop him from the talk, and this is called the pressure of talk. And of course, this patient, as he talks a lot and has a pressure of talk and he has racing thoughts, he will fly from one idea to the other. And sometimes you don't get these ideas connected. So this is called flight of ideas. It's a form of thought disorder. And again, if you try to talk to him in a subject, he will be distractible. So these are 6 symptoms. The 7th symptoms actually comes in the physical activity. So if this patient is energetic, so he will have increased physical activity. Either goal-directed, so he's a student, so he'll study a lot. He will go and meet his friends. He will go to his gym, play his workout, and keep going and going and going. These are called goal-directed activities, and it's okay to have them as long as we have a good judgment. But sometimes we lose the judgment, so we get, for example, he goes to the workout, so he spends 4 hours in the gym, lifting weights and so on, so it comes with an emergency problem. Afterwards, he goes to the hospital for a heart problem or something like this. So there's usually a poor judgment in his increased physical activity. Or the physical activities comes in a non-goal directed, and this is called excitement, and the patient here is aggressive. So he can hit persons, sometimes he's homicidal, he can burn, set fires in churches according to his belief that he's going to save the world from non-Muslims populations. And we've seen it in homicidal excitement for the manic patient, for example, the patient that killed, set fire in a bus of tourists, or set fire in a church, or entered into a mosque and killed the people that prays there. So we have seen this in the excitements of manic patients. So you need a 1 week duration of this energy, elation or irritable mood, plus 3 or 4 symptoms of item B to have a diagnosis of manic episode. The hypomanic episode, also again, you have the same criteria. But what differentiates manic from hypomanic symptoms is, number 1, the duration. Manic needs a 1 week duration. You can diagnose hypomanic from 4 days only. The symptom severity and need for hospitalization usually is higher in the manic episode and not in the hypomanic episode. Again, if we have psychotic symptoms like delusions or hallucinations, it goes for the manic, and it is never, the psychotic symptoms never comes in hypomanic episodes. Now we come for the depressive episodes. Again, the depressive episodes, you need 5 symptoms in 2 week duration of the following. The depressed mood, and in children and adolescents, maybe irritable mood. The patient feels sad, he feels of loss of interest and activity, he has no pleasure in the things and the usual activities that he performs. For example, he used to go to his training and he loves it. He used to read something, he used to enjoy following series in the TV. He lost interested in all of this in the depression phase, and this is usually because doesn't get any pleasure. And when he doesn't get any pleasure, this is a term that we call anhedonia. So one of the 5 symptoms in the depressive mood must be either the depressed mood or the lack of interest or loss of pleasure. And then we go for the other symptoms like psychomotor retardation and or agitation. The psychomotor retardation, for example, we have daily activities, we go for it. In the manic, he's energetic and he does them and he goes for the activities all the time. But the depressed patient, on the other hand, has this diminished energy, and he's retarded in his daily activities. Sometimes you get agitation, and we mean by agitation is, again, it's aggression, but not as in the manic patient, aggression towards others. No, it's aggression towards self. So we might find a lady crying or hitting herself. We might find a man hitting his head into the walls. So this is as an aggression directed towards self, and this is called the bouts of agitations. It usually comes in bouts, not all the time. The other symptom is the sleep symptom, which we might encounter in depression as insomnia or hypersomnia. The typical symptoms is insomnia. The atypical symptom is hypersomnia. He sleeps a lot and he doesn't want to come out of his bed. So this is the atypical symptom. The insomnia usually that comes in depression, it's usually because of the depletion of neurotransmitters. So the patient will sleep. He will come and sleep. He can initiate his sleep. And then at the middle of his sleep cycle, he will wake up with a middle insomnia or early morning awakening. He wakes up before the time he has set to his alarm or his usual morning awakening. So this is the insomnia we get with the major depression. Another symptom is the appetite changes. So the typical symptoms that the depressed patient will lose his appetite and there will be a loss in his body weight. While the atypical symptoms, he will eat a lot and he will suffer from hyperphagia and increase in weight gain. And for a weight gain to be judged, we need a change of more than 5% in 1 month with the loss or with the gain. So we have until now 2 atypical symptoms I would like you to know for the depression, which is the hypersomnia and the hyperphagia. Now we go for another symptom in depression, which is the fatigue and loss of energy. We talked about that causes the retardation, the physical retardation, and fatigue gets to be a very common symptom, a somatic symptom in depressed patient. It is in nearly 60% of depressed patients. That's why most of depressed patients goes to the internal medicine doctors before they reach to a psychiatrist. Some cognitive changes occurs in depressive patients with decreased concentration, forgetfulness, and indecisiveness. So they cannot concentrate when you talk to them, so they get the forgetfulness, which is not something organic as we encounter in dementia, but sometimes a patient would come only with forgetfulness, a depressed patient, and we can here give it a name like pseudo dementia, depressive pseudo dementia. Again, the patient who is depressed would have certain negative thinking because he's not able to do anything. He's sad, he has lost his energy, sometimes he feels fatigue, so sometimes he feels that he's worthless or has a low self-esteem. I'm not as others. I'm really at loss here. So for the depressive episode to be diagnosed, we need 2 weeks duration with 5 symptoms. One of them is the depressed mood, loss of interest, or the loss of interest and lack of pleasure. And then we were discussing together the symptoms for the depression. We went through the depressed mood, we went to the diminished or loss of interest in daily activities, we went to the psychomotor retardation and agitation, we went to the loss of appetite or the hyperphagia, and we went through the insomnia and hypersomnia, we went through the fatigue and the loss of energy that comes into 60%, nearly 60% of depressed patients, and make them go first to seek advice from the internal medicine doctors. And the cognitive symptoms in the form of decreased concentration and forgetfulness that might account to depressive pseudo-dementia, not a real dementia, and the indecisiveness that most of us as psychiatrists, we tell our patient never to take a decision during such a depressive episode because they cannot really choose, colored by their negative thinking. And then we come lastly to the negative thinking of the patient, that he's feeling he's worthless, or sometimes he reproach himself and blame himself for something that he did in the past with sense of guilt. And this sense of guilt actually is very important, because sometimes depressed people feel so guilty that they feel that God will never forgive them, and that's why they might commit suicide. So presence of guilt in a patient, depressed patient, is actually a premonitory risk for suicide. Based on this negative thinking, we might have in a patient that will be associated with psychosis, mood congruent delusion. So the mood congruent delusions actually will come as follows. The patient will think that he did something sinful and he feels guilty. So this is his first mood congruent delusion, which is the delusions of guilt. And then he will become reproaching and self-blaming himself. So this is the delusions of self-blame. And then he might think that God has punished him with this illness, and this will get us to the delusions of deserved punishment. Sometimes the deserved punishment comes in the form that he will think about, I've lost an organ, or an organ is diseased, so he'll have somatic delusions or hypochondriacal delusions. And these delusions usually have the sense of depression, so these are mood congruent delusions. Again, some of his thinking, a depressed patient might feel that he has lost his worth, and here, or the word has lost his worth, it has come to its final. So these are the nihilistic delusions famous of depressed patient. So when the patient has these negative symptoms, we are actually very alert, because the next step he's going to think of death, and then he might have a suicidal plan and he might commit suicide. 10 to 30% of depressed patients think of suicide, and 10 to 20% actually succeed to commit suicide. So this is a very dangerous situation in the depressive episodes. Now, the mixed episode that I told you about, I mentioned it early, that it comes in the DSM-4, not the 5. It has been removed because actually it has no clear ground for diagnosis. It has been used, it has been diagnosed early by the presence of alternate discrete mood timing in the same episode. The same 1 week of the patient is suffering from mixed episode. In the morning you enter, he will be elated for 2 hours, and then after you enter the ward to check on him in the afternoon, he's going to cry at the same mood episode. And there are symptoms that can come in a depressive episode and a manic episode at the same time, like the hypertalkativeness, like the aggression, like the sleep disturbance. So we used to diagnose a mixed episode by this, the presence of the alternating discrete mood periods between elation and depression, and these similar symptoms. But the DSM-5 has removed it and has put lots of specifier. One of them is the mixed specifier. So you diagnose a depressive episode, and if you find this patient has a reactivity in his mood, or he becomes elated at a time and become energetic or hyper-talkative, or has loss of sleep, we can say that this patient has a depressive episode by the criteria with a mixed specifier. And again, we can make it with the panic. After you diagnose a manic a full-blown picture of a manic episode, and you find this patient crying or has some negative thinking, or he is not sleeping well, we might again say that this is a manic patient with with a mixed specifier. Other specifiers I would like you to know is the psychotic features that we have just mentioned for the delusions and hallucination for manic and the depression, for the manic and the depressive episode. And these features might be mood congruent, that comes with the mood, like the delusion of grandeur and the other delusions we just mentioned, the guilt, the self-blame, the self-reproach, the somatic delusions, the nihilistic delusions in the depression, or it might be mood incongruent. Another specifier is the melancholic specifier. Here it comes for the depressive episode only. The melancholic features here, it means that the patient is really sad. He has a distinct mood quality of sadness. He has this mood with a diurnal variation. In the morning it's worse than at night. He has the sense of guilt. He has a middle or early morning insomnia. So this characterizes the melancholic features of depression, and usually it has a great biological origin related to the monoamines deficiency. Anxious distress is a new specifier. The depressed patient is also anxious. We used to diagnose it as mixed anxiety depressive disorder, or we used to adjustment disorder and anxiety depressive and anxiety type. But now we say it's a depressive episode with an anxious distress features. Again, the atypical features is a specifier, like the hypersomnia and the hyperphagia we have just mentioned. And sometimes depression and mania comes with catatonic features, which is a motor abnormality kept in a patient for more than 24 hours, like the posturing, like the negativism, like the mannerism, like the stereotype. So that concludes our clinical picture for the episodes. As we come for the bipolar, we need to diagnose after you had the patient, you elicited his symptoms, you counted the symptoms in duration, you got 3 episodes with their specifiers. Now you need to put them into diagnosis: bipolar or a depressive disorder. So to begin with, if you are going to have a manic or hypomanic episode, then we left the depressive disorders. We're only sticking to bipolar disorders. To differentiate bipolar 1 from bipolar 2, you need to have the presence or absence of a manic episode. So bipolar 1, you need to have manic episode while loud and clear, while in the bipolar 2, you don't have, it has to lack the manic episode and only has a hypomanic episode. Of course, they can come interchangeable with depressive episodes. And don't forget in your differential diagnosis, please, that some medical condition can cause manic episodes, and some substance that the patient use can cause manic episodes. Like, for example, medical condition like the thyrotoxicosis, you can have thyroid mania, and the substance like, for example, the cannabis, like the amphetamines, like the heroines and cocaines. For the depressive disorders, we will have a depressive episode that you need to differentiate it from all the types that we have encountered, and I would like to add on them the grief. Grief is normal sadness that any one of us experience towards loss of a relative, loss of a girlfriend, loss of a property, loss of money. So we have normal sadness. So I would like you to put it in mind when you're differentiating a depressive episode. And then again, the medical conditions, the general medical conditions that causes depression, like tumors in the frontal brain cortex, like endocrinal conditions like the thyrotoxicosis, like the Cushing syndrome. So we have, again, to exclude these general medical conditions. Again, substance induced depressive disorders are present, like the antihypertensive, which depletes the monoamine neurotransmitters responsible for your mood. So antihypertensives can cause the depressive disorders. Again, corticosteroids can do that. And never forget the contraceptive pills in women, especially in the childbearing period, which may cause depressive disorders. And then after you exclude this, you need to see the depressive episode. Is this a part of a major depression? Usually this have certain criteria, like no stressor or trauma has been exposed to the patient, comes usually out of the blue, the diurnal variation of the sad mood and the depressed mood, the middle insomnia or early morning awakening, the guilt sensation. Sometimes they have psychotic features and they lose insight and judgment. The persistent depressive disorder is a minor depressive episode, but it has been present for a long time, 2 years in adulthood and 1 year in childhood and adolescence. The adjustment disorder depressive, usually it has a stressor, and the patient will come complaining that he cannot cope with this stressor, like, for example, the multiple exams that he's in our college, and usually medical students has this problem. The stress that comes from family, the trauma that he has been exposed in a natural disaster or with his beloved ones. So this is usually clear and loud, and then you will have the depressive symptoms that we have just mentioned with them. And secondly, to the stressor. So these are the depressive disorder you need to know. And again, some of the MCQs to test your understanding till now. That leads us to the last part of our lecture today, which is the management of mood disorder. We usually have the management lines in our psychiatric disorders as any disorder: hospitalization, whether we'll use a biological therapy, and we have a very special part that we are professional at, which is the psychotherapy. For mood disorders, the first line is the hospitalization, and here we have indication for hospitalization, like for example, you need to make sure of your diagnosis, you need to make investigations and imaging to exclude in general medical conditions or substance use. Another indication is the lack of social support for the patients, nobody to look after them or give them care. Another thing is that the patient sometimes, like in a depressive episode, he refuses food, he is non-compliant, he refuses medication, so we need to hospitalize him for that. Aggression towards self, like in suicide, or aggression towards others in homicide, is again an indication for hospitalization. What we mean by the second line of treatment, which is the biological therapy, is the drugs or the electroconvulsive therapy. Now, electroconvulsive therapy is a very safe and rapid treatment in psychiatry, contrary to the stigma it has been put in social media. Actually, it relieves a lot of aggression, suicide, homicide. It can be used for the psychotic features, can be used for the catatonic features. It can be used for resistant depression or resistant bipolar disorder. It can be used even safely in pregnancy in the first trimester if you don't need the teratogenicity of drugs, or it can be used in the old age patient where he's taking lots of drug and you don't want the complexity of drug-drug interactions. So this is the electroconvulsive therapy. We usually give them for all the indications I just mentioned. The second part of biological therapy is the pharmacotherapy, or our drugs, the psychotropic drugs. So we have two disorders, the bipolar and the depressive disorder. We start with the bipolar disorder and the drugs we give there. So the patient will comes in an episode. Your treatment in this episode is the acute phase treatment. Okay, so you usually go with the acute phase treatment 2 months after the remission of all symptoms. When the patient have no symptoms for 2 months, we continue we change from the acute phase treatment to the maintenance treatment, because this is a disorder of remission and relapse. So we have an acute phase treatment and a maintenance phase treatment. We immediately start the acute phase treatment with mood stabilizer, which will continue with us to the maintenance phase treatment. The mood stabilizers here has a crucial role of shortening the episode, of giving spacing between one episode and the other, and prevention of the relapse. At the same time, if an episode comes with a patient taking mood stabilizer, it will be shorter in duration and lesser in severity. So a mood stabilizer is our first treatment. Our father drug of mood stabilizers is the lithium salts, or the Prionyl as it's present in the market. And it is initiated in the acute phase treatment. We usually give it from 800 to 1,200 milligram per day, and we want to reach a therapeutic serum level from 0.8 to 1.2 milliequivalent per liter. And then this patient, the manic patient or the hypomanic patient, cannot sleep. He's talking all the time, he's energetic, so we need symptomatic treatment plus the mood stabilizer. So we usually give them the antipsychotics or the sedatives. Antipsychotics, which are the dopamine receptor antagonists, or recently the serotonin dopamine receptor antagonists. So this is for the acute phase for the manic and the hypomanic symptoms. For the depressive symptoms, if it is for the first time, the acute phase treatment, usually we don't initiate a mood stabilizer, but we give an antidepressant and we follow closely. And usually the duration of this antidepressant will be given in the form from 6 months to 1 month. Okay, so we have a bipolar disorder with a manic or hypomanic patient. Initiate your mood stabilizer, give symptomatic treatment in the form of sedatives, antipsychotics, and then reach for the maintenance phase treatment. For the depressive disorder, first episode, we are going only to give the antidepressant for 6 months to 1 year, hopefully, if the patient is compliant, and that's it for the first episode. For the second episode, we usually give the antidepressant plus a mood stabilizer, and we go with them for the maintenance phase. So in the maintenance phase for the manic and the hypomanic disorders, or the bipolar disorders in general, we need to maintain on the mood stabilizer. So for example, if you're if your patient is on lithium, we will lower the serum level into from 0.6 to 0.8 milliequivalent per liter. Usually it comes with 1 or 2 tablets per day, 400 milligram. And we either maintain on only the mood stabilizer, or we make some combinations that will further prevent the relapse in the patient. So we might combine it with another mood stabilizer, or with another mood stabilizer and antipsychotics, or we might go with 2 antipsychotics only. And this is called the bipolar combos or combinations. Now, I would like you to give some hints for the drugs. In a depressive episode, you might have depressive episodes in the bipolar disorders, right? We have manic, hypomanic, and depressive episodes. So when the depressive episode comes in a bipolar, as a part of bipolar disorder, it is very difficult to treat, and usually it becomes chronic. And our hands are really tied to give antidepressants, because one of the disadvantages of antidepressants is the manic switch. It removes the depression and it makes the patient happy. So this is, if it goes for severe happiness, it will be a manic switch. So we usually, our hands are very tied to give antidepressants. So what we do with a depressive episode as a part of bipolar, we call it bipolar depression. First of all, we increase the mood stabilizer. We might give an antipsychotic with an antidepressant effect, like the quetiapine or the ziprasidone, and we might resort to ECT if the depression didn't go away yet. And lastly, we might give an antidepressant, usually with the least manic switch, from the category of the noradrenergic, dopaminergic reuptake inhibitors, like the bupropion. As another tip I would like you to give for the major depression with psychotic features, these features are resistant to treatment with antidepressant alone, so we give antipsychotics to treat the psychotic symptoms, and it gives, and the electroconvulsive therapy again gives a marvelous response for such a disorder. Now we finished the hospitalization and the second line, which is the biological therapy, whether the electroconvulsive therapy and the pharmacotherapy, and we go for the psychotherapy. The psychotherapy is not only a talk therapy. We conduct it with the patient through certain techniques to support and target the symptoms of the patient. So we have lots of techniques, like for example, this supportive psychotherapy. Supportive psychotherapy is indicated when a patient come with adjustment disorder depressive type. So his coping strategies are really little to adjust with the stressor in his life. So we give him supportive psychotherapy, where we give him we teach him how to the problem solving techniques. We give him the chance to ventilate about his stressors. We give him the chance to reorganize his thinking. And then we have the cognitive behavioral therapy, which is usually given to major depressive disorder. As we said before, when we were describing the negative thinking of the depressed patient, of his worthlessness, of his hopelessness, of his helplessness, we pick these thinking, and we call them here the cognitive distortions, and we try to correct them with behavioral tasks, and this is the theme or the theory for the cognitive behavioral therapy. Sometimes for bipolar disorders, when they finish their treatment and the episode is gone, they quit treatment. So sometimes we try to give them therapies to increase their compliance with the treatment, like the compliance enhancement therapy that we give for the bipolar disorders. And with this, we come to the end of our lecture. Thank you very much, and I'm looking forward for your discussion.